So welcome to the first of our new webinar series, our 2020-2021 CHWN webinar series. So I'm very pleased to have presenting with us Ali Coates and Mara Mihailescu, who are part of the Canadian Health Workforce Network. And thank you, Mara. So first of all, to acknowledge land, and you'll see many of us have our orange shirts on. It's Orange Shirt Day. And so we want to acknowledge that we are gathered across Canada on territory of First Nations, Inuit, and Métis. Here in Ottawa, where we are based, we are located on unceded territory of the Algonquin Anishinaabe Nation. And we extend our respect to all First Nations, Inuit, and Métis people for their valuable past and present contributions to this land. And this graphic is just for you to recognize where you are located and also recognize that there are treaties in those territories, and we should take time to know our treaty. We include this land acknowledgement as only one very small gesture as part of disrupting Indigenous erasure and dismantling colonial structures. So thank you for that. So I'd like to introduce the sponsor of our event today, Jennifer Zelmer, who is with us here from the Canadian Foundation for Healthcare Improvement. And I would like to give her an opportunity to give a little bit of introduction about how she thought about this project and then how we partnered with it going forward. So welcome, Jennifer.
Thanks so much, Ivy, and thank you to everyone for joining us today. Early in the pandemic, we spent some time thinking about what kinds of information, what kinds of supports, what kinds of tools might be helpful 6 weeks and 6 months out. And one of the things that we know is true, not just during pandemic times, but in general, is that healthcare is all about people. It's about the people who are responsible for organizing and delivering services, and the people who are involved in the care process in many different ways. And boy, are we seeing now during the pandemic, it's also about the actions that each of us as individuals takes. But it was that reflection on the importance of people and our commitment as an organization to more improvement with and for more people that lasts, that led me to reach out to Ivy and her colleagues at the network to say, how can we understand, because lots of people are going to be trying lots of things in the course of the pandemic, how can we understand what different types of strategies are being tried related to the workforce? And how can we understand what we can learn from those and where there might be opportunities to accelerate the spread of those that are most effective, and learn from those that seemed like a good idea at the time, but might not have panned out in the way that was expected, so that others don't necessarily go down that same path. And so we were delighted to partner with the network to pull together some of that information from Canada and more broadly, and also to undertake some analysis so that we could understand more about what was happening. So with that, Ivy, back to you, because today is the culmination of a lot of that work.
That's super. Thank you so much, Jennifer. And Mara, we'll get to the next slide. I remember receiving the phone call from Jennifer to say, could you do this? And I answered yes before I thought about anything else. Because we all, I think, just wanted to do something, and this was a way to actually do something. And the very next call was to Ali and Mara to kind of say, do you guys have capacity to do this? And so it was really having Ali and Mara and their ability to work on this. So so I'm just going to introduce a couple slides before Ali and Mara present some of the summary data that we are getting out of the database to date. And so really we're looking at health workforce strategies in response to the COVID-19 pandemic. But it is a little bit broader than that, and Ali will give you some descriptions about that. So next slide, Mara. So as Jennifer mentioned, she contacted us at CHWN in March of 2020 to undertake a rapid review of innovative health workforce strategies to mitigate the effects of the COVID-19 pandemic for patients, population, and health workers. and to curate that in a readily accessible platform for a range of users. So this was always to be open access and to be as user-friendly as we could possibly make it. And this presentation outlines the progress to date of what we have incorporated into the database as of the end of August. Nothing has been added since then, but there have been a number of other projects, so we will continue to add to it. But this is a summary of progress to date. So I'll pass it back to you guys.
Thank you so much, Ivy and Jennifer, for the introduction. We're just going to start doing a little bit more background than what Ivy has given, and then we'll really dive into what we found. So the COVID-19 pandemic has really created this burning platform for a focus on the health workforce specifically. So here in Canada, we have the Canadian Institutes for Health Research, and one of their institutes, the Health Services and Policy Research, conducted a rapid cycle priority identification process, and they published their COVID-19 research priorities, in which the health workforce figured prominently. So their priorities discussed the pressures faced by healthcare workers due to lack of PPE, high workloads, and safety concerns, as well as how the workforce was deployed and supported to provide COVID-19 care, understanding the facilitators and barriers to a coordinated and effective response, the strategies and policies that could be implemented to improve workforce planning, capacity, and safety, as well as the role of family or other informal caregivers and what they played as part of the health workforce, and the impact that COVID-19 had on their health and mental health. So when we look at this diagram here, the health workforce capacity is really integral to the health system capacity as a whole. And so that dotted line across represents this capacity. So often it's represented as a flat static line. However, it's not. It can really move up and down depending on how the workforce is mobilized. And the reason why we've been focusing so much on flattening the curve throughout the pandemic is to keep the demand on the health system below that upper limit of the health system capacity.
So in order to meet the volume demands within any sector of the health workforce, policy interventions can take the goal of increasing the numbers of the health workers within a cadre, increasing the flexibility within and across cadres, or by increasing support for workers in order to maintain their availability to work. In the first category, increasing numbers, we had heard about a lot of mechanisms to call back or incentivize retirees to return to practice, to fast track trainees, to draw from pools of internationally educated health workers, and to facilitate the mobility of health workers across jurisdictions. And one of our key questions that arises with many of these solutions is whether and how reskilling should or does occur in those scenarios. In the second category, we looked at mechanisms that would increase the flexibility of workers. So leveraging the areas where scopes of practice overlap or where they can be expanded. Here we would see interventions like task shifting or skill mixing, delegation, and redeployments across or within sectors. But we also saw the opportunity for new models of care, like virtual care. In this category, we were concerned with the cross-training or the upskilling that may or may not occur with these rapid changes in workforce flexibility. And then finally, our third category that we looked at was to increase the availability of the existing health workforce in a sector through a variety of supportive practices, like, for example, providing childcare services to frontline workers, providing housing for redeployed workers, or providing mental health supportive practices to health workers. It also included providing the IT support and infrastructure to support this rapid shift to telehealth. So we needed to be very clear about our objective. The needs presented by the COVID-19 pandemic were widespread, and they were not unidimensional. An early model that circulated in social media from Dr. Victor Tseng depicted the multiple and overlapping curves of needs presented by this pandemic. And we chose to focus specifically on the first purple wave on this chart, which addressed the acute and early needs of the health system when COVID hit. And it was predicted to happen in 2 peaks. And of course, we do see ourselves right in the middle of the second peak right now, right on schedule. This chart shows us the dramatic reality that it's not the only way that the health system will need to respond to the pandemic. The second wave, which is the one in green, will have seen the impacts of resource restrictions and shutdowns on the treatment of other non-COVID urgent restrictions. And we have seen some of that pressure already. The third wave, which is in blue, shows a similar but a later upswing in demand that is based on the pent-up demand for care for chronic conditions that was where the care was delayed or deferred, or where the conditions have worsened because of a lack of continued care. And then finally, beginning right at the earliest stages and mounting over time, we see this continued wave of mental health issues that arise in the healthcare workers and in patients alike after living through this experience.
So our approach for undertaking this work was really a 3-step process that you see. So first, for our inputs, we conducted an international scan of promising strategies identified in the published and gray literature, and also through online submissions that was available to anyone to discuss strategies that they've implemented or strategies that they've seen. And then for our coding step, we took all of those online submissions and literature results, and we screened them for completeness and then coded it according to a set of criteria that we'll discuss later. And our next planned step is the assessment of these strategies by an international panel of experts for quality and safety concerns. So our outputs were an online open access searchable database that's hosted on the Canadian Health Workforce Network.
So as Mara said, one of the inputs to our coding process came from a search of the published literature. We looked at peer-reviewed journals and indexed trade literature to uncover any already published COVID literature addressing workforce strategies, but more importantly, to learn from previous emergencies and disasters, which might similarly stress the health system, which led to responsive changes in the health workforce. To do this, we searched for experience that we could draw from natural disasters and previous health emergencies like other pandemics, where the pressures on the health system would be immediate, complex, and sustained over time. Our search in Medline, Embase, and Cinol produced about 3,600 results, which we screened according to a set of inclusion and exclusion criteria. And in order to be included in our database, a specific population health event or natural disaster had to be described, along with at least one workforce strategy being discussed. In parallel with the database work, we aim to produce a rapid scoping review, which would include any of the identified workforce strategies where outcome evaluation was performed and reported in the literature. Of the 3,600 unique results obtained through our database search, 2,926 were excluded from the analysis through a title and abstract screening. The remaining 464 were full text reviewed in duplicate, and 100 articles contained sufficient information for inclusion in our database. Another 41 were included in both the database and the forthcoming scoping review. Of the published pieces that were included in the database, 43 of them did relate to COVID, and 6 had enough outcome evaluation data to be included in the synthesis work. Out of the full body of literature that was included in the database, half of the published literature came from the USA, with the majority coming of the remainder coming from the UK, China, Italy, and Canada.
So our gray literature search and screening was a little bit different than the published literature. So to start our gray literature search, we created a systematic gray literature search tool that was inspired by the Canadian Agency for Drugs and Technologies, or CADTH, checklist that they had used for their own gray literature searches. And we designed this tool to help us systematically search the relevant health workforce organizations and document all aspects of our search process, including where and what results we found. So it outlined a list of health workforce organizations, including associations, regulatory bodies, societies, research institutes, and leadership organizations at the pan-Canadian or national level, provincial, and territorial levels in Canada. And we're also working to expand this internationally as well. We also searched some of the CADITH recommended databases that were relevant to health workforce studies. So after searching each link, we inputted the relevant results into our search tool, and then we went back and fleshed out the strategy in our coding form and coded it according to our categories. In total, we searched 855 links for organizations, and we extracted a total of just over 1,000 results. And of those, 483 were coded and included in our database. So the discrepancy between those last two numbers comes from duplicate strategies being added to the coding form, as well as the removal of results that weren't relevant. So when we search the organizations, we really lean towards being more inclusive regarding what's relevant. And then when we went back to code the results and we fleshed out everything, we often excluded several for being outside the scope of our work. Our third input was an open and online form that was open to the public, and we crowdsourced a total of 22 submissions and included 16 of them in our database. And the excluded results were, some of them were lacking the necessary information and contact info to follow up. But what was good about them was that a lot of them focused on a more international landscape, so that was a great addition. When we look at coding these strategies, this was completed not only for our own analysis, but also so the strategies can be easily searched in the database. And we did this through an online form. We coded thematically across those three focal points that Ali mentioned of increased numbers, flexibility, and availability, as well as for provider groups, geographic region and setting, organization, and by type of evidence available. And we managed discrepancies among our coders, myself included, through conducting a duplicate searching exercise for reliability really early on in our coding, and keeping open communication, running through examples together to make sure we're coding on the same page. And we also kept track of our results under the correct source organization to prevent overlap and duplication in our search tool.
The team acknowledged early on that a lot of the strategies that we were collecting would benefit from an expert opinion to help us understand the actual impact that the intervention might have, as well as to understand the risks that might be presented either to health workers or to patients or to the health system. As well, we hoped that a panel of experts could give an assessment of confidence in the intervention based on the evidence underpinning it and any follow-up analysis done. In order to collect volunteers for this task, we've created a form that's linked in this presentation that allows our international experts to volunteer to review some of the interventions in the database. This form allows for people to identify their specific areas of expertise. And due to the short time frame that we had for executing the project and the quantity of the strategies that we found, it didn't allow for an expert review of many of the proposed solutions so far. So we hope to continue to gather the expert assessments, and we encourage you to participate if you are interested. We currently have well over 600 entries in our publicly available open access database. Because our search strategy and our funding mandate focused on the Canadian grey literature, Canadian interventions predominate in our database. The remaining included workforce strategies came from the US, which was largely influenced by the dominance of that country in the published literature. And as well, we got a smattering of other submissions from across the globe from our international collaborators in that space.
So when we look specifically at the Canadian sources, the largest number came from Ontario, British Columbia, and at the pan-Canadian or national level. And oftentimes many organizations in other provinces linked back to resources within these jurisdictions. So if we look to the Canadian chart, I just wanted to note that it includes both provinces and territories, as well as the entries coded at the national level. And this just had to do with the way that the coding was done. So some grey literature was at the pan-Canadian level, another at the provincial level, but both types are representative of those Canadian results. So in the table on the left, you see the types of evidence that we coded for in order of prevalence. The majority of evidence we've been finding has been in the form of formal strategy, formal policy, and informal strategies, and this is likely because of these sources that we searched. So formal strategies were things that involved a change in practice that were associated with a formal change in regulation, and they were likely articulated by a formal organization of some kind. Formal policies are issued by some sort of governing body, whether it's the government, agencies, or associations, and they involve that formal change to regulation. And then the informal strategies are things that might be found in news articles or newsletters, listserv groups, among others. And I just wanted to note that research interventions with outcome data available were notably absent in our search. Across our thematic areas or our foci, the largest number of strategies addressed, followed by increased numbers and increased support or availability. And it's important to note that many of the strategies were coded within multiple foci, so it could be counted both under numbers and under increased flexibility, for example. So for the top strategies, these are the highest yield strategies based on the total number of entries coded for each one. And these are a form of sub-strategies for the thematic categories that you just saw in the previous slide. Again, many of the entries were coded with multiple strategies, and the most prevalent strategy was telehealth or virtual care. And this was followed by expanded roles of health workers, licensure flexibility, cross-sector staff deployments, and the provision of mental health services to healthcare workers. "294 of the innovations that we collected aimed to increase the numbers of healthcare workers. Some of the strategies used a single mechanism, such as licensure flexibility, to facilitate multiple strategies, which could include cross-jurisdictional assignments, cross-sector deployments, or the return of retirees or fast-tracking trainees. In many cases, multiple mechanisms were used to incentivize healthcare workers to return to practice, for example, by waiving fees, fast-tracking applications, or subsidizing insurance. So some notable examples for this category is temporary emergency registration. This type of registration allowed former workers to return to work, and it also allowed trainees to get a fast track on their licensing during the pandemic to increase the health workforce capacity. This was also part of the rapid response, with most of the licensing starting by being available for only around 4 months with the potential to extend, and many of them have. And this was also common across many of the health professions, including nurses and pharmacists, physicians, dietitian, midwives, medical radiation technologies, and also across Canada. So from the published literature, the same approach was seen. And in this example, the NHS had asked retirees to rejoin the workforce, and they provided mechanisms for medical students to be fast-tracked into practice. As well, agreements with the private sector in the UK had given the NHS immediate access to over 20,000 healthcare professionals. So the use of temporary registration and temporary training really facilitated that return to practice of retirees and new grads. And as we've just mentioned, utilizing new medical grads was another strategy to increase numbers of health workforce. And this is an example of licensure flexibility and fast-tracking trainees. So during the pandemic, certification exams were delayed, so recent grads that needed to complete the exam to finish their training couldn't get licensed. However, with the help of these types of licensing, it was possible. So trainees were really able to help increase the health workforce capacity because they have the knowledge and the training to provide the required care. So this example specifically is a joint statement by the Canadian Association of Emergency Physicians and the Society of Rural Physicians of Canada that recommends utilizing new grads as a strategy to increase capacity, specifically for rural emergency departments. And they recommended a mandate that recently graduating MDs with provisional licenses because of that delayed certification exam can do locums, be assigned billing numbers, and sign employment contracts.
Over half of the strategies that appear in our database involve, at least in part, increasing the flexibility of the workforce within and across cadres. The most prevalent strategies for increasing worker flexibility included virtual care and telehealth, expanding roles, and cross-sector staff deployment. Telehealth, or virtual care, which is one of the ISPER research priorities, played a part in almost a third of the strategies that we collected. Other prevalent strategies across geographies included the expansion of roles, deployment across sectors, or the creation of new roles to meet new or changing needs.
So as Ali mentioned, virtual care was the most prevalent strategy to increase flexibility. And if we look to who was using virtual care, it was pretty common across many of the health professions, even those who hadn't provided virtual care before, such as chiropractors. So one of the most common virtual care platforms across the professions was Zoom for Healthcare, which is a cloud-based video conferencing software approved for the delivery of virtual health because it has those additional security measures to protect the privacy of personal health information. So the use and implementation of virtual care was facilitated by licensing for platforms, licensure flexibility for interprovincial virtual care, and new payment policies and billing codes that were created specifically for this. As well, there's a gap in the literature around rural and remote access to virtual care. There's very few, if any, innovations that are specific to improving or addressing accessibility of rural communities to virtual care. However, even though a lot of the innovations or strategies are not specific to rural or remote settings, there's still several that are applicable in these settings. And interestingly, the published literature showed little reliance on virtual care or telemedicine in response to prior pandemics or disasters. However, many telemedicine and virtual care solutions were described in the literature specific to COVID-19. In terms of redeployment to long-term care, that was another strategy that required increased flexibility of healthcare workers. So for this example, the Ontario Centres for Learning, Research and Innovation in Long-Term Care created an online orientation to help those workers that were redeployed get ready to work in long-term care settings. So the orientation had 4 sections and they focused on foundational knowledge, communication and person-centered care, providing support in long-term care, and personal care, all of which are important to help provide care in that setting.
So this example of expanded roles came from epidemic responses in Africa to Ebola and in South America to Zika. In both regions, community health worker roles were expanded in the face of these pandemics. In Africa, CHWs performed disease surveillance, symptom reporting, and targeted patient education regarding Ebola. And during the Zika outbreak in Brazil, CHWs in some rural and remote communities triaged patients in their communities, provided basic care for the minor things, and directed more acutely ill patients to seek care from medical providers. The strategies that increase the availability of health workers in practice through supportive mechanisms revealed a great deal of variation and creativity. There were 217 database entries that addressed these supportive practices. Of these, the provision of mental health supports to workers in practice was the most common, and we're going to hear a bit more about some of these. Other popular supports involved training or infrastructure for a shift to virtual care, housing or home services support for frontline workers, and the provision of childcare to keep working parents able to work when the schools and many childcare facilities had closed. Fewer formal strategies were found in this category of innovation. A lot of these innovations arose spontaneously to meet a need, sometimes initiated by people who found themselves suddenly out of work or school due to COVID-related shutdowns.
So some noteworthy examples of mental health services because this was the most prevalent strategy discussed to increase availability. We have psychology works and healthcare worker assists, as well as informal peer support strategies. So a lot of these were services that were provided by mental health professionals that really volunteered their time to provide these virtual mental health services to frontline workers. For example, Psychology Works for COVID-19 was developed by the Canadian Psychological Association, who called on registered psychology practitioners to consider donating some of their time to provide psychological services. Another more informal example is a daily Zoom call that Dr. Mamta Gautam created and led as a free daily peer support service and not as a psychiatric care support as some of these other services. And this innovation was really circulated around on Twitter, which is a great use of social media. So from the published literature, a hospital in China provided robust mental health and wellness support for their frontline workers. They also provided leisure activities and training on how to relax, as well as psychological counselors visited the staff quarters to listen to their stories and provide the appropriate support. So all options require change management considerations in both the short, medium, and long term, and they also entail potential barriers and facilitators to their adoption, their adaptation, and also their implementation. Each of these inputs, barriers, and facilitators exist at different levels. So here you can see our guiding framework for the analysis of barriers and facilitators to health workforce strategies. And it's a modified and simplified version of the conceptual framework from the Canadian Academy of Health Sciences. So just to go over it, at the heart of the model is really the individual health professional, and that professional has a particular scope of practice that's derived from their education, their training, and their experience. And they are situated within a practice, an organizational, and a system level context, which can foster or impede them working at their full scope. So at the practice level, this includes factors that influences the scopes of practice, such as interpersonal and interprofessional relations between health professionals and many previous experiences these professionals have had working with the other professions. So at the organizational level, this includes the existence of organizational arrangements with hospitals, other healthcare institutions, or community settings, such as technological supports and their interoperability that can help or hinder collaborative interdisciplinary practice. And factors at the system or policy level include the legal, regulatory, economic, educational, or curricular level influences on the effective use of health professional skills and scopes of practice. And these can be at a health systems level, especially with respect to legislation or funding, and at a health professional body level, such as education and the regulation of the profession.
At the system level, one of the factors that enabled some of these solutions to work was the provision of professional guidance or toolkits, whether these were new or whether they predated COVID. We found this a lot, especially in the rapid transition to telehealth. Many professional bodies created or circulated resource materials and best practices to help various healthcare professionals quickly transition to provide their services virtually. Similarly, license recognition across jurisdictions facilitated a number of the solutions, including the ability to provide virtual care outside of the jurisdiction of licensure, or the ability to redeploy health workers to areas of need. At the health system level, changes in legislation, including the creation of new fee codes, supported a rapid adoption of virtual care, which had been proceeding very slowly in Canada prior to this, in part due to the lack of such structural supports. Some barriers remain to be overcome. For example, many concerns are expressed that the shift to virtual care may have been too rapid, leaving questions of whether, when, and how virtual care is safe and appropriate, and presenting new equity issues related to inequalities in access to the technologies and telecommunications infrastructure required, as well as the technological skill and trust required by patients to access such care. One of the concerns here that persists is that many of the changes that were made are temporary accommodations. Further work is needed to formalize and make permanent the changes that should be maintained and to safely roll back those that should not. We saw barriers and facilitators at the organization and practice levels as well. Notable examples here included various allocation tools to help administrators plan and adjust their workforce, as well as various funding opportunities, for example, from hospital foundations to help with unbudgeted, unpredicted expenses relative to the workforce. Scheduling and staffing rules within organizations, as well as inflexibility in skill mix, hampered organizational and practice level response to the COVID-related workforce needs. Across all levels and all jurisdictions, collaboration and leadership were important facilitators of strategy development and adoption.
So in terms of limitations and next steps, our methodology was focused on the more formal strategies and policies, and therefore less is written or submitted about the practice or organizational level. Also, the time frame of the present study didn't allow for follow-up of missing data, nor beyond that first wave response that we saw in the first few slides. And because the response to subsequent waves of the pandemic is presently unfolding. So future research of this kind would be instructive, especially including an explicit evaluative component, because across all our inputs, very little evaluation had been undertaken of the pandemic response and the strategies involved. Additionally, research interventions, as I mentioned, were notably absent in the literature, and some interventions have planned assessments, but there have been none so far that have been published.
So thank you so much, Mara and Ali, and for the presentation. Here's a little bit more information about how to access the items in the database. So that's a specific link that's provided there. If you are online or know of strategies that aren't in the database, you could actually add them through our online form. And if you want to help out assessing the strategies, you can volunteer through this other little link. And also, you can always get in touch with the project via this email. And yeah, so I wanted to thank everybody for that. Also to note that this is the first of our webinar series. We will have another one coming up in October on health workforce governance with our CHWN co-leads, Chantel Demers and Kate Leslie. And in November by our mental health lead for the Canadian Health Workforce Network, Mary Bartram, on a new project that we're just about to embark upon. So with that, I think we'll open up for questions and comments. And the first one that we have is from Peter Dodick. And so Peter has two questions in part. So first, thank you for tabulating these ideas. Was there any explicit appraisal to evaluate if these ideas can work in terms of efficacy or feasibility, and if they do work, effectiveness? And so I think, we spoke to some of these issues, but Ali, if you want to give a few more details in terms of what you found in the published literature, and Mara, what you found that your team found in the grade literature, that would be great.
Sure. So I think while it should be surprising, it actually isn't that surprising to hear that a lot of these ideas that we propose in an effort to be helpful and to do something or to feel like we're doing something, a lot of the ideas are never really followed up to see how many people took advantage of those particular opportunities and whether or not they were successful in achieving their goal of either increasing numbers in a certain area, increasing flexibility, or increasing support to workers. Certainly, there is a very little formal evaluation of these types of strategies in the literature. And one of the things that I think we were a little bit surprised about, but then not really when we thought about it, is the idea that even in the published literature, when people are reflecting back, none of this is planned. It's an emergency response. It should be planned. We should have ideas of what to do in an emergency situation. But then, when we do all of these innovations, these things that we change up on the fly, we don't build in the evaluative component. And so as we look to the previous disasters and emergencies that we reviewed in the published literature, the best that we get in most situations is like a list of lessons learned, not really a true quantitative assessment of efficacy or qualitative assessment of efficacy. There were a few notable exceptions in the literature, but honestly, we're talking about maybe 5 in the 42 articles that we included that had any sort of post-emergency look back.
Yeah, I would also echo what Ali said for the gray literature as well. I think the nature of the gray literature didn't really allow for that type of follow-up. And the only ones that I can think of that had any sort of data were actually news articles. And they focused on a specific case or a specific location. And they would mention this many beds were inputted or this many workers were redeployed. But outside of that, there wasn't a lot of going back and seeing if the strategy was effective or if the implementation had changed anything and what would be good for others to do as well.
Yeah, it's really unfortunately typical of the health workforce field that a lot of the interventions, like regardless of COVID or otherwise, are not really assessed in terms of impact. So it means that this field of science, health workforce science, becomes very underdeveloped because of that lack of follow through. So this we see as really kind of a first step, and hoping that we can sort of take it the next step forward. A sub-question that Peter had raised was wondering about unintended consequences of these ideas, both positive and negative, and were these considered? And before I post that to Ali and Mara, just to kind of highlight, this was in part why we decided to add the component of people with a health workforce background to do some sense of assessment of the level of risk around some of those unintended consequences. And just because of the size of the the number of innovations that we've found and the timing, that hasn't been as fully developed. But again, that would be sort of based on the information that we gathered, and some of it is really quite incomplete. But Ali, could you speak to that issue?
So I absolutely agree with that. It's always hard to track the unintended consequences of something, especially when there's no formal evaluation that's been done. So I think what we see a lot of in the published literature is people's anecdotal recollections of what happened in these disasters. So a lot of the published literature, unfortunately, isn't even from the peer-reviewed literature, the stuff that got identified in our search. It's from trade journals, a lot of nursing journals. So we got a lot of personal narratives of response to prior emergencies. And so while we can glean some of the lessons learned from that, it's really not a formal assessment. So that was something that we did recognize early on and would really like to continue using international experts who have some expertise in these various areas, whether it's a certain profession or a certain sector, to help us understand how these interventions may have some degree of risk, have a certain degree of impact. Maybe they're very low risk, but they're very high impact, or maybe they're low risk, but they also aren't going to do a whole lot. It would be really great to know that. And I think with the time that we had available, it wasn't possible to, pull enough international expertise to get a well-rounded assessment of that. It would be important to understand that this is not a database of things that works. It was a database of things that happened. And so it's still very much an evaluation that is yet to be done, and is encouraged for people to take these innovations and follow up on them.
Mara, would you like to add to that?
Yeah, so the one thing I picked up on Ali's response was really that anecdotal piece. And I think the gray literature is going to be really important for that moving forward as well in the second wave, and really people reflecting on what had happened initially and how we responded to that and how we can learn or improve our response and the organizational response, and talk about that kind of in the gray literature landscape, whether it's through newsletters or blog posts or just even more informally than that, and pick up on some of those lessons learned and that evidence that may not be a formal evaluation but important nonetheless.
Absolutely. And Peter's follow-up is just thank you for the answers, and perhaps these limitations in evaluation could help inform a research agenda, and that's absolutely what we would like to do, is to summarize what we have here. And because it's an open access database, you know, we want to encourage all of the members of CHWN or non-members to look at the database, gather together a subset, and, you know, help us flesh them out, you know, fill them out a little bit more. We also didn't have time to sort of follow up with people in terms of key informed interviews, but that would be something really helpful for us to say where we didn't have enough information. And that was particularly prominent in the areas around barriers and facilitators. A lot of the information, it was really hard for us to garner that, but that would be a really interesting set of a follow-up. So we're quite happy to partner with anybody to embellish those aspects. So our next question is from Jean-Luc Bedard, who said, I missed parts of your methodology. I guess you worked with a list of keywords. If so, did you have French keywords as well to get documents mostly grey literature only in French and not labeled with English keywords? Very important point. I'll have Mara ask or answer that question first, and then we could provide a little bit of feedback.
Yeah, so for the grey literature, we really just did a, we would take a link and do a search by reading through all of their tabs. And if they did have a search bar, we would usually just search COVID-19 or pandemic. So we're hoping that the COVID-19 would have really captured some of that French literature, especially on the French sites. I am not French speaking, unfortunately. So we had another team member who did speak French, and she handled the majority of the grey literature that was in French, written in French or on French websites. Some of that came out of Manitoba, New Brunswick, a lot in Quebec. So we did capture some French, but I'm sure throughout our search, there could be more lurking behind there, and French keywords would be really instrumental in that. But our search was very general to COVID-19.
Absolutely. Thank you, Mara.
So
Ali?
I guess I'll just chime in to echo that, you know, by having a human search based on a very broad key term, we were able to reduce the number of specific French words that we needed to target. So we weren't relying on the vocabulary to capture it. We were relying on humans to crawl through all of these websites. In the published literature, we used English keywords, but we did include articles in French. And there were a handful of them that came through. I don't think any of them ended up being included in the database because they didn't meet our criteria, unfortunately. But we did set French as a potential or as an allowable language of publication.
That's super. Thank you, Ali. And thanks, Jean-Luc. We absolutely welcome your input to complement that. And that's in part, you know, why we wanted to have this webinar, to let people know what we have so far, but we want to continue to build this going forward. Yeah, absolutely. Thanks. So there's a question from Sonia. Thank you for this work. We have been recently funded to investigate health leaders' crisis leadership strategies by Research Manitoba. Looking forward to contributing to this knowledge base. And I just wanted to kind of highlight this notion of health leaders, and whether or not Ali or Mara, you found anything from in the published literature or grey literature specifically looking at leadership or health leaders.
From the published literature, I can say that we did not, and that is maybe a limitation of our search that we didn't consider at the outset. We didn't include key terms that address leadership. We assumed that they would come in as a result of the other key terms that we included, but I can't recall any specific leadership targeted interventions that we found in the published literature.
I don't think there was any in the grey literature either specific to health leaders. There's definitely involvement of health leaders in creating some of the grey literature pieces that we did include, but there wasn't anything that that I can recall that was specific for health leaders or being implemented specifically by health leaders. But that is a really interesting theme and something that we can totally go through and see if we can pick up on any of that as a thematic category.
I agree, and I will note that one of our user submissions from our colleagues internationally, one of our user submissions was targeted towards leaders, and so in the database we have at least one that is specifically oriented towards leadership.
That's great. Thank you for that comment, Sonia. So this is absolutely a huge opportunity that we can use to kind of build that, not just on terms of the work that you're going to be looking at. Happy to share the database. It's really quite easy to use the filtering process of that we've used. They're online sort of Google Forms. And it's a sort of a natural way to get the information out and to have people come and utilize it. So looking forward to those conversations. The next question is from Hussein, who said hospitals work on less than 50% of their capacity today. So asking any documentation regarding reshaping this capacity to provide services differently. Strategy-wise to cover shortage of staff, in other locations. So go first, maybe Tamara. We'll have you, and then maybe Ali.
Yeah, for sure. So we actually came across a few health workforce capacity calculators, and I also connected with somebody who provided a submission, an online submission on one of these calculators that he had developed. So I think there's work being done in terms of understanding how a hospital functions and how we're allocating beds and how we're allocating staff and where they go, especially with the implementation of COVID-specific wards. So definitely that was something that came up in the gray literature, mostly in terms of tools that help you restructure, not in terms of the general how the restructuring is being done, but whichever organization wants to take this on, there's tools out there to help you. So that was great to see. And there's a couple of them in the database.
So as far as the published literature goes, we weren't looking necessarily at tools to help reshape capacity, but looking at things that happened. And some of the things that people ended up showing was conversion of spaces that weren't previously used for health services. And so maybe that's, hospital tents, which was something that was big in natural emergencies, natural disasters, but also in COVID response for putting hospital tents in the parking lot to expand capacity pre-hitting the hospital doors, right? To do some of that pre-screening and to do some of the respiratory testing. So I think that there were not maybe the things that we wish that we could provide to you in that regard, but it's definitely an interesting question.
Excellent, thanks. So that's it for the main questions that people have put in the chat. If you have anything else or a specific thing, I know that Ali has been updating everybody about the links to the database or the volunteer assessment forms, and we're very happy to partner with everybody. This is really about getting information out as much as possible. What we can do now is just close off officially the webinar. We'll stop recording, but if anybody would like to stick around and have a conversation, we can unmute you and converse more broadly, but we will use this as the time to close off. And thank you for your patience, and apologies again for the technical difficulties at the outset, and we really appreciate your interest and support. So thanks everyone.
Thank you.
Bye.